Okay, thank you. Oh, for Christ's sake. There we go. All right, so the consonant phenomena. What it is basically that the range of motion at one joint varies with the position of another joint over which a common tissue runs. So the obvious one is straight leg raise, although this applies to all of them. The amount of hip flexion you have available depends on the knee position and to a lesser extent on the position of the ankle. Because over the two of these, you've got the hamstrings and the gastrocs. So if I bend the knee, you get more range of motion at the hip. So, okay, now, this is important because if this is how you tell whether you have a constant length phenomenon or not. So this could be a hip joint restriction, in which case, providing that the hip joint restriction is below the maximum straight leg raise with the knee straight, then you know that this isn't part of a neuromeningeal problem or anything else that relies on the constant length phenomenon. Does that make sense? So it's a fairly standard, I mean, you know this, but I don't know if you know the term or not, but this is the proper term for it, constant length phenomenon. So, come on, move yourself. There we go. What we have are these tests. These are the sort of standard tests, and we're going from top to bottom. So neck flexion, just standard neck flexion, of course, that's going to pull on the entire dura and the spinal cord and its extensions out. So this will stretch all of the neuromeninges to some extent or another. And where it's most obvious is with meningitis. In fact, this is a standard test for meningitis. So the head goes forward and you reproduce, usually not just pain, but a compensatory movement at another area. So for example, you put the neck forward and what you tend to see is the back arching forward to take it off. In fact, with severe meningitis, the patient will be on their heels and on the back of the head, and the whole body will be arched into extension just to get the stress off of the meninges. Otherwise, we tend not to use it for this, but we use it as a sensitization test for the other neuromeningeal tests. Okay, so it's not really a primary test for us. The problem you've got is if you've got somebody with back pain, upper back pain, scapular pain, that area, and you do neck flexion, you may well reproduce the pain in the upper thoracic spine and believe that it's coming from the neck. And unfortunately, sometimes it is coming from the neck because the dura is multiply segmentally innervated, and it can refer a long way down into the upper back. So you've got this problem. Neck flexion is neither a specific test for the neck, nor is it a specific test for the meninges when you're looking at upper thoracic pain. We've got the upper limb dynamic test. Now, these are put down as tests of the, well, all of these are put down as neurological tests of the neurological tissues. But this is the one that seems to be only the neurological tissues, and it really isn't necessarily. It's also a bit strange in as much as these tests, once the dura is stretched by taking the head to the opposite side, these tests then no longer stretch the dura. What they do is they move the nerve root in and out of the dura. So at some point or another, this does become a neurological tissue test, a neurodynamic test, but it isn't entirely that. So the basic test is contralateral side bending and abduction of the shoulder. The sensitizations for this is basically elbow extension, elbow flexion, wrist extension, wrist flexion. And this will tend to sensitize it to different parts of the neurological system, so the brachial plexus, all the way down to the peripheral nerves running over the wrist. Putting your hand on your head, this one. Not many people teach this or know about it, but if that relieves the pain in the neck, and allows you to get better movement, for example, then this is a pretty good test for the C7 dural sleeve. Now, I've never seen any research backing this up, but from clinical practice, this does seem to hold. And this, as far as I know, this was first described by Syriacs. Scapular retraction has the same sort of credibility as far as research is concerned, because I've never seen this before. But scapular retraction anatomically will stretch the T1 and probably the T2 dural sleeves. Slump with and without the leg maneuvers. Without the leg maneuvers, it's really a test for the thoracic cord and the meninges. That is the thoracic tissues. When you add in the leg maneuvers by doing a straight leg raise, dorsiflexion of the ankle, inversion, and so on, then it tends to sensitize it for different parts of the lumbar spine and lumbar sacral plexus, and of course the peripheral roots. And I'll come back to in a minute. We can discuss just how useful some of these tests are. But that's without the leg maneuvers. I've left with it, but it should be there. Prone knee flexion, L3 spinal nerve root, and it's the meningeal sheaths and the femoral nerve. Slump tests proper, the way we normally think about it, for the legs, including the legs, as I say, is thoracic spinal cord, cauda equina, L4 to S2 spinal nerve and roots, dural sleeve, sciatic and tibial nerves, everything really running down the back of the legs. The straight leg raise, L4, 5, S1 and S2, roots and nerves, the meninges, their meninges, sciatic and tibial nerves again. So is there anything there that is new to you as a different slant from what you've heard before or seen before?
No.
No?
I hadn't seen the scapular retraction one before.
Yeah, okay, it's not bad. It's not a bad test because it really doesn't stress anything else in the spine. And I mean the spinal column itself. So it really does separate a lot of this out, because neck flexion, for example, you're moving the joints, so the pain can be coming from the joints. Straight leg raise is similar. You could be coming from the spine itself, it could be coming from the SI, and so on. But this one really doesn't stress. It puts the thoracic spine into extension, but from about T3 through about T6. But it really doesn't do very much for the upper two levels, and it really doesn't do anything much for the neck. So in this case, this is actually quite a specific test for those two segments.
And so you're just looking for a reproduction of symptoms?
Yeah, yeah. Now you can sensitize this, of course, because if I've done that and then I do neck flexion and the pain gets worse, then you've got an even stronger indication this is dural. And I guess if you actually, it's the same with all of these, if you're wondering whether this is dural or neural, it depends on the symptoms being provoked. So if you're getting somatic pain, you know that this cannot be neural. And if you're getting neuropathic pain or paresthesia, you know that that can't be dural. Often, not often, but sometimes there's a mix. But even so, even if there's a mix, you know, something is going to be neuropathic and the other one is probably dural. But I think with all of these tests, there's this, it's actually not much of a confusion between neuropathic and somatic tissue stressing. The real confusion comes to whether or not you're doing a dural test or a structural test for the musculoskeletal system. And this is where the sensitizations actually do come in. Is that okay? Anything else on this? No. Okay, so this looks at sensitizations now. Neck flexion, you can sensitize in meningitis anyway, because this is not going to give you neurological symptoms. It's going to give you somatic symptoms, but you can sensitize it by doing a straight leg raise, scapular retraction sometimes, and slump. So all of these would tend to sensitize this towards the idea that it's dural. Otherwise, I say it's really not a dural tests that we use. It's worth noting, though, that if you get neuropathic pain, particularly lancinating pain or paresthesias going down the body, then you could be looking at quite a nasty disease, something like MS. But it's certainly not the only one. It is the main one, though. But any myelopathy could do this as well. But there's a few different diseases that will do this. So this is not a good sign when you get neurological symptoms shooting down the spine or paresthesia going down the body. Then you've got to be thinking about a cord problem, really, is what you're looking at. And in fact, if you think about it, the Sharp-Purser test gives you, it's called Lermit sign. So Sharp-Purser test, if you're doing it to reduce symptoms, the symptoms must be of Lermit sign, that is neuropathic, either paresthesia or lancinating pain. And this is my argument for not doing a Sharp-Purser when you actually do get those symptoms. So you put the head forward and you get those shooting symptoms. Now, doing the Sharp-Purser test where you reduce it by bringing the head back actually becomes risky because you have no idea what's happening in the cord. This could be a large disc herniation. It could be an Arnold-Chiari malformation, for God's sake, that you could destabilize by keeping the head there. So this is not Sharp-Purser's test anyway, but you shouldn't be maintaining a position that's producing these types, and especially if they're undiagnosed, neurological symptoms. Is that okay? Have we talked about Sharp-Purser test yet? Anybody remember?
Yeah, we talked about it one weekend when you were trying to ask us if we used the test or not, and how sensitive it was. Yes.
Okay, so we chatted about it. Okay, but this is one reason for not using it as a reduction of symptoms test. It's actually the reason for not doing it for that. The other thing is, what do you care if you put the head forward and they get paresthesia or lancinating pain all the way down their back? You know it's neurological. What do you care what the disease process is? Your job is to get it the hell out, and you can tell you what's happening. Yeah. Okay, so the upper limb dynamic tests. So contralateral neck side flexion, shoulder abduction is common to all three tests. So you can sensitize it by doing elbow flexion and wrist flexion, which is the radial nerve, wrist extension and elbow extension, which is the median, elbow flexion and wrist flexion, which is the ulnar. Now, if you're really going to argue that these are neurological symptoms, then they must be neurological in quality. That is, it has to be lancinating, parasitic, or coursalgic. We good there? Now, if we look at how useful these things are, well, let me ask you, how many of you use these?
I do.
Okay, when do you use them?
Well, I'm just looking at how you're describing it. Like normally if somebody's talking about symptoms down the arm, I'll go into that, but I think I could be better at differentiating between the dural versus neural.
Okay, that's fair enough, but that's simple. I mean, that's really a simple thing. We know what the neurological tissues the symptoms that cause. We know what somatic tissues can't cause, which is neurological symptoms. There's your separation. That's really quite simple. Now, if we're talking about symptoms going down the arm, is that pretty much everybody? You do these when you're getting neurological symptoms or arm symptoms? Because there's an argument for doing sort of both of them up to a point. But what conditions, actually that's new on me, what is that? I've got a 0 in there. Can anybody see it? Or is that just me? What the hell is that? Okay, well, let's do it this way. What conditions, what conditions would these tests be positive? Reasonable question, isn't it? So what conditions are you testing when you do these?
Peripheral nerve injuries.
Sorry, what?
peripheral nerve injuries.
I just want a condition.
Sorry, I didn't hear that.
I just need a condition that you're going to, when these tests are positive, you can say, oh,
Oh, yeah, oh, okay.
Yeah. So what have you got?
Okay.
I'll give you one. Disc herniation. There you go. Now, are there any more?
Possible severe stenosis.
Okay, stenosis, severe or not, but we'll say stenosis. So we've got lateral and central, so we'll look at both of those. Any more? Is that it? Those two? So you're all thinking spine. Why? Have you got any peripheral conditions that this might be useful for?
I do it sometimes even for tennis elbow, just to rule out any kind of nerve involvement with that.
Okay, we'll come to that. What about carpal tunnel syndrome? You're going to get exactly those symptoms with that, aren't you? And this test is actually built for that. Radial nerve, radial neuropathy. So all of these peripheral neuropathies were actually what this test is based on. That's why you do these sensitizations. It's a maximally stretched. It's not, if you think about this, do you need these tests to tell you that you have a disc herniation with a radiculopathy? Are these tests necessary for that? If you didn't do these tests, could you still diagnose a disc herniation with a radiculopathy? Of course you could. I mean, it's not that big a deal. Lateral stenosis with a radiculopathy. Is that a problem for you? The only difference between lateral stenosis and a disc herniation causing radiculopathy is the intensity of the pain between the two. That's it, really. They both cause a radiculopathy, and a radiculopathy has exactly the same signs and symptoms regardless of its cause. So you don't need it for that. Do you need it for somebody coming in complaining of carpal tunnel syndrome symptoms? I've got paresthesia through here. What else can it be? I've got a radial neuropathy. Do I need it for that? Do I need it for any of these things? An ulnar neuropathy. You don't really need this test to diagnose a radiculopathy. Of all the things, and a neuropathy, you really don't need these tests to make that diagnosis, except in extremely atypical cases. So using these as a routine test, because you have a radiculopathy or a neuropathy, really makes very little sense at all. What about if your tests for carpal tunnel syndrome, Phelan's, Finkelstein, that don't work? Then this test actually becomes useful. So if I find that I cannot reproduce these symptoms any other way than by doing a full stretch, I mean, it's up there, by doing a full dynamic test, then I can say probably somewhere else in that line is involved as well. So what I'm looking at now is possible double crush syndrome. So these tests are pretty good for picking up double crush syndromes when they work. I don't know, when they don't work, that's the problem. But when they work, you can say with a fair degree of surety that this is a double crush, at least a double crush, if not a triple crush. Yeah? So standalone tests are useless. As etiological tests looking for double and triple crush problems or multiple crush problems, they can be useful. But looking for neuropathy, you really don't need them. Looking at a radiculopathy, you really don't need them. How much time is spent learning these tests and then doing them on every patient who comes in, and it's a complete waste of time. When has ever these tests changed your opinion on what the patient's problem is? Has it ever? I'll give you it's a patient, shoulder problems. That's it. He's got pain in the shoulder. You come in and you start doing the upper limb tension test for no good reason at all, and you find that all 3 upper limb tension tests are positive. Okay, so you've got me in that position. The hand goes back, it's positive, down there, and so on. All 3 tests are positive. He's had none of those symptoms previously. Now, what are you going to do with the results of that test? This is part of the problem of doing them routinely. In fact, it's a big part of the problem with doing it. It's a big part of the problem of doing any test routinely, is it may throw up positives that are completely irrelevant to what you're doing and what the patient's feeling. So what do you now do with these tests? You ignore them, didn't you? Or do you dig into them deeper? It may give you an insight of the shoulder, though. Why would I have positive tests when I do this test that are not present at any other time?
I find sometimes with postural changes, say they have an injury in their shoulder and they're holding it a certain way, or say pec minor or something seems really tight, that ends up creating positives in these tests because it's compressing on.
Well, I know that of all the muscles, I would think that pec minor isn't it.
Okay, any of the muscles throughout the shoulder.
But does it? Does it really? Look at this. Let me give you another, for instance. I go in and I depress the shoulder because I'm testing the glides. All right, so I'm testing the inferior glide of the shoulder, and they now get pins and needles in the hand. Where are those pins and needles likely to be coming from?
The shoulder.
Shoulder. So if I've got a hypermobile or unstable joint where the humeral head is depressing too far, when I push it down, it's going to contact the brachial plexus. And that can give me this paresthesia. Now that's useful because now I know that I've probably got an unstable shoulder. But the symptoms itself doesn't mean anything because there's no pathology present. A lot of these cases, there isn't any pathology present. Sometimes you put them on a strong enough stretch anyway, and you get the pins and needles. And it may be that you're tightening muscle up across one of the components of the brachial plexus, possibly. But what does that mean? It means that the muscle is not tight. It's just you've tightened it up enough that it actually starts to become an issue. This could actually be in the neck muscles. Yeah. So doing this test as a routine really doesn't make any sense. It doesn't actually make any sense to do any test as a routine diagnostic test. Now, it may make sense to do tests routinely when they're safety tests, but not as a diagnostic test. It's the same as doing by being a physician and doing every single imaging that you can all over the bloody place, because the patient's coming with neck pain. So you're going to image the entire arm, the neck, and you're going to do MRI, CT scans, PET scans, and so on to see what's happening. That doesn't make any sense neither. Your imaging should be focused on what you think the problem is, not on where the problem is. Yeah, this is no different. Your physical test should be focused on your hypothesis of the diagnosis, because you cannot disprove a diagnosis by doing every single test. Yeah. Anybody else got a problem with that? Anybody want an argument? What's the matter with you? I was going to ask you if you can see that, but it doesn't really matter because I can't. There we go. So upper limb dynamic tests. They have their uses, but they're seriously overused. When these tests came Actually, I think Syriax was the first one to come up with an upper limb dynamic test, and it was the ulnar nerve test. And then, oh, damn it, I've forgotten his bloody name now. The Australian guy. Elvey. Elvey then developed a bunch more, and then who was the one who popularized all this? Can't remember his name. Anybody remember it? Maybe it was Elvey who popularized. I can't remember anyway. Something like 400 or 500 papers was written on this in the first 3 years when this first was popular, but it's died off a lot now. But there's not a lot of point in doing all of these tests all of the time. That's all I'm saying to you. Head on the hand, there are no sensitization, except you can do neck flexion. Scapular retraction is the same. No, actually, head on the hand, there aren't any. If you do neck flexion, you're likely to bring the pain back. So this isn't a sensitization, but it's not a bad differential test. So if you put the hand on the head, pain goes away, then bring the head forward and the pain comes back, that's probably what you're dealing with is dural. Scapular retraction, neck flexion. Slump test without maneuvers is the thoracic. You can sensitize it to the upper thoracic by doing shoulder retraction. And you can, of course, sensitize the whole thing by doing neck flexion, which is common to all of these. Prone knee flexion, what people tend not to do is neck flexion and a slump when they're doing this. Do you ever have this on? Or not? You have to do it in side lying. So you do the prone knee flexion in side lying. I do it in prone first if it's positive, then put them on their side, do it again. But now you can add in neck flexion, you can get them a slump as well. All of this will sensitize prone knee flexion. Slump test, you can sensitize it the way you normally do, neck flexion, straight leg raise, and ankle dorsiflexion. And let's talk about slump test as well, can we? How many are you doing slump tests as a routine? So you're going through, you're doing a scan of the lumbar spine. How many of you doing the slump test?
I do the slump test,
You do?
not routinely, but I do it.
When do you do it?
Same thing, like if they've got that radiating leg pain.
Okay, fair enough. What about everybody else?
I do it to show them that they need to do like a slider or something.
You mean mobilize it?
Yeah, so I show them why they're doing the exercise that I've given them, basically.
Okay. Anybody else?
Yeah, I do it when they have the radiating symptoms and I'm not getting anything from SLR and I need to kind of do something extra. So I do the slump test.
Okay. Anybody get any other reasons? So, do you do slump and straight leg raise? Got Kim saying no.
Not typically, no.
Okay. Why pick slump over straight leg raise?
Usually because they're sitting, and so it's just if they're really painful, sometimes to get them laying down time.
Well, you can still do a straight leg raise and sitting, but you're adding the slump on as well.
Yeah.
So the difference between straight leg raise and slump is not the position you're testing in. I can do a straight leg raise perfectly well in sitting. I can do everything involved in a straight leg raise, neck flexion, dorsiflexion of the ankle and so on. I can do all of that in sitting. So the difference between the two isn't the position you're testing in.
I guess I've never considered that, but yeah, that makes sense.
So if we look at the two of them, which one is likely to be more sensitive? Now, I'm assuming that we're going to talk about the straight leg raise with all the sensitizations on. So we'll come back to, I think that was you, wasn't it, Bola? So you said you do it with the straight leg raise is negative? Okay, so the straight leg raise is negative. You then go and do the slump test. Why?
Yeah.
There's only one good reason for it, is that it's more sensitive. They both do exactly the same thing except for the slump. So the argument is that the slump is increasing the stretch through the neuromeninges. Yeah. Okay. So it must be more sensitive. Now, which is more specific?
SLR.
Yeah, because you've not added that extra joint movement in. Because what you may be doing is when you're getting the positive from the slump itself, is you're doing a lot of compression in there. You're getting a posterior shear involved. So all of that may be adding not to the stretch, but to the, well, it does add to the stretch to some extent, but to the pain produced. Yeah. So this is my other question. If I have a negative straight leg raise and a positive slump test, what's the next thing you should be doing? What we just talked about. Is this slump causing a stretch on the dura, or is it causing more pressure on the spine? This stuff's not as easy as you taught in school, is it? It's not as clear cut, it's not as straightforward.
No.
Well, what I could do is take some of the stretch off. That may change it. I could do PAs on the spine and see what's happening in the spine. Am I reproducing pain? But of course I am, because they come in with back pain. I can do a compression test to see if that's a problem. The problem is all of these tests are not really giving me a lot of hard evidence. How good is the compression test? Does it reproduce what's happening with the slump test? Actually, it sort of does. If I bend the knees up, then the spine kyphoses, which is that part that you're interested in, isn't it? You're not interested in the amount of compression going through the spine. You're interested in the position of the spine to stretch the dura. So if I bend the hips up, yeah, I'm going to kyphose the spine. Now, what I could try and do is do a straight leg raise in that position. Now, I obviously can't hold that. I'm going to need another person to do this. So I get somebody else to do the straight leg raise, yeah, and see if that's positive. Because if it's not, all we're talking about this being a spinal issue and not a compression, not a dural issue. Now, you might think I've got to get somebody else to do it, but how often do you ever find the straight leg raise negative and the slump test positive? Doesn't happen very often. It's very rare. And especially when you add in all of the other stuff. If the slump is negative, or if the slump is positive, straight leg raise is negative, and then you take dorsiflexion off of the ankle, for example, or a little bit of knee flexion, and the pain down the leg goes away, then I would have no argument with you as this being meningeal. If that doesn't happen, then the slump test isn't testing the neuromeninges. Also, what sort of lesion are we looking at here? If let's assume that we've got a true positive slump test, it's meningeal, but the straight leg raise is negative. What sort of lesion are we looking at here that is so minor that when would the patient ever complain of this pain? What activity would give him pain that would only come at the end of a full straight leg raise? Can anybody think of anything? So you're going to have to be, you can't see me, but you're going to have to be like driving a car. Your legs are going to have to be out in front of you. Your ankles are going to have to be dorsiflexed. You're going to have to be looking down at your crotch. Now, if you ever drive like that, let me know, will you? I'll stay off the road. The only activity I can think of that will come anywhere close to doing this might be hurdling. So it's difficult for me where the patient would ever complain of these symptoms. Now, you might argue, and it's a reasonable argument, that they have a minor dural adhesion. Yeah. And that's only showing up at the end of these ranges. You still have to wonder when the patients ever can complain about it. But okay, that could do it. And in which case, whoever, I can't remember who said it, about using basically mobilizing the neuromeninges. That might not be the worst argument of the world, but we'll come back to it. But when did they get this adhesion? The other thing is, if you're doing a slump test, and do you do it unilaterally or bilaterally? With the legs? Which is it?
I test both legs.
Simultaneously?
No,
Okay. What's the purpose of testing both if they've got unilateral pain? Actually, it's the same reason for doing this. Is the problem with doing the slump test and not doing the straight leg raise first. The straight leg raise is almost certainly going to be positive. Now, if you've got a positive straight leg raise, is there any point to doing a slump test? No, because you're just adding one more confounding factor in here. So you would never do a slump test if the straight leg raise is positive. It makes no real sense. Unless you're doing it, as you say, to mobilize and show them the effect of it. But if the straight leg raise is negative, don't do the slump test. If the slump test is positive, do the straight leg raise test. Because that's how you take out not the kyphosis, but the compression loading through the lumbar spine when you do it. So that's all it should be done. Is if you're going to do the slump test, it's done when the straight leg raise is negative, the slump test is positive, and then you've got 10 minutes of trying to figure out what the hell is going on when that happens. Yeah. Answer this question for me. I can take any patient who doesn't have neurological symptoms or dural symptoms come there, but they've got no pain, all right? They've got no back pain, no leg pain. I can take any person like this, and it's more obvious to see on somebody with a normal straight leg raise, say 80 degrees of straight leg raise, 70 or 80 degrees you can at the other ends, but nonetheless, it works on everybody. It's just more obvious. You can do this. I do a straight leg raise. I get to the limit of the straight leg raise, and they're talking about tightness through the back of the leg. Now, what will happen to that straight leg raise if I then have them lift their neck up? Will it increase, stay the same, or decrease?
Sorry, did they have a positive straight leg raise?
No, this is a normal person. No back pain, no leg pain. They've got the same limitation on both legs, which is normal. All right. I then ask them to lift their neck up while they're in that position. What will happen to the straight leg raise?
So in an ideal world, if it's a hamstring stretch, it wouldn't change it.
Okay. Anybody else? A lot of this is not counterintuitive because you believe a certain thing often. If I had prefaced this question by asking you what limits the straight leg raise, you might have said hamstrings. But now I'm going to say something, because usually what happens with that question is the straight leg raise will decrease. I'm not saying you're wrong, Nanny. I'm saying this is a normal response. It's a straight leg raise will decrease when I do neck flexion, or if you like, I do straight leg raise without neck flexion, I get a certain measurement, I do then flex the neck and I get another straight leg raise and it decreases. That's typically the answer, because although you understand this to be a hamstring limitation, you're thinking that the dura actually limits the straight leg raise. It doesn't. The hamstring does. But what happens is when I do neck flexion, I increase the straight leg raise. And this is probably a form of vestibular reflex, vestibular spinal reflex. But the tone in the hamstring goes down when you lift your head up. It happens in standing and it happens in laying. So the straight leg raise actually increases when I do this. Try it. You don't have to believe me. Try it. Just do a straight leg raise, get to the end of range, have them say, yeah, that's it, thank you. And then get them to lift their hand up, and then you just push it a bit, not stretch it, just move it, and it will move up a bit more for you. There's much more to the straight leg raise. There's much more to all of these tests than is taught typically, and certainly in schools. Much, much more. So the reason that you get a positive straight leg raise when you have a neuromeningeal hypomobility is because you don't get the muscles involved. This kicks in well before muscle tone does. And if anything you're going to get is not muscle tone increase, you'll get spasm of the hamstrings and stop you doing the straight leg raise, which is a totally different animal. But the pain and the spasm, well, the pain comes on first, the spasm comes on very, very rapidly afterwards. And that's what limits the straight leg raise here. Yeah. So it's a lot more complicated. And you also have to consider that if you're going to do mobilizations for a dural adhesion, which are rare, because you have to ask yourself, I think they've got a dural adhesion because the straight leg raise isn't very limited. And the question there is, how the hell did they get those adhesions? So, and the most common way of getting a dural adhesion is a disc herniation. But you have to ask, where did that come from? Adhesions don't just form, they form because of injury, bleeding, and inflammatory processes. So you always have to ask yourself that. And that's what I'm saying to you. If your straight leg raise is negative and your slump test is positive, then you have to wonder what's going on. Also, try this on people. Not necessarily patients, but do a straight leg raise with them in sitting, straight up sitting, then do a straight leg raise with them slumped, and then do a straight leg raise with them kyphotic. Which one do you think is going to be limited in those three positions? Neck involved or not? In fact, don't involve the neck, just as a complication. But of those three positions, slumped, straight, kyphotic, which one?
Slumped.
It's kyphotic. And it's limited by a hell of a lot. You can lose 50% of the straight leg raise. Now, certainly things feel tight, but this may be because you're shifting the attachments of the muscles. I honestly don't know. There's not an awful lot of difference between the three things. The pelvis tilts a lot, but I think it must be a mechanical effect. I can't think of what else it can possibly be. Also, if you try this, do a straight leg raise, do some hold relax techniques near the end of it, and you'll get a lot more straight leg raising occurring after the hold relax techniques, which shows that it's actually the hamstrings or hip extensors that are limited in straight leg raise.
If you do that hold relax, are you, and it is something dural, are you at risk of flaring it up then?
Yeah, but that wouldn't happen anyway, because what you're getting is hypertonicity or even spasm in the muscle. So that's not going to happen.
Okay, yeah.
And the problem with all of these things that you do, as soon as you start doing things like hypertension, mobilizations and stuff, as often as not, they flare up. So you've got to be real careful about the diagnosis and the way you're doing this. And a lot of this stuff, I'll show you on the course, but I can increase these movements in the upper limbs, ranges of motion, everything, just by moving the eyes. So a lot of what you're gaining when you're doing these so-called mobilizations is muscle tone decrease. And if you don't get rid of the cause of it, it's going to come back pretty damn quickly again, because it's hypertonic. But you can get rid of a lot of this tone simply moving the eyes. I'm sure there's other easy ways as well. But most of the stretching that you do is pointless. If you're stretching a tissue because it's too short, the question is, why is it too short? If this is structural, then stretching is the way to go, preferably by splinting rather than anything else. If this is neurophysiological hypertonicity, then stretching is the most inefficient way of getting rid of it by a long way. Hold relax works hundreds of times better than stretching ever will. So the only good reason to do a stretch for length is because you enjoy it, or because it's actually a structural problem, and then you're going to spend a career doing that. We good? Okay, so slump, straight leg raise. All right, straightforward enough. And you can change this around. Ankle dorsiflexion, be a bit careful because it does increase, and you know this, how tight the gastrocs gets when you do dorsiflexion. So if this starts giving them what they call pain behind the knee or down the calf, just make sure it actually is because of straight leg raise. And the way to do that is to keep the dorsiflexion of the ankle on and take the straight leg raise down. If the pain stays the same, then it's not neuromeningeal. Very occasionally, neck flexion will reduce the pain that you get with a pathological straight leg raise. And it doesn't happen very often, but it's actually quite telling when it does. And it's not what I was talking about before, about reducing tone because of a vestibular spinal reflex. This actually is a pathological straight leg raise, a disc. In fact, you do a straight leg raise with a disc, you get it positive at 40 degrees or whatever it is, and I do neck flexion and the pain eases off and you can actually get a bit more straight leg raise out of it. And a very good argument is, it works often as you see a disc herniation like this anyway, is that most of the disc herniations are going to come out and hit the nerve on the lateral side of it. So when you do a straight leg raise, it's positive. You do neck flexion, it pulls it up against it. Sometimes that will go into the axilla of the nerve. Straight leg raise is positive, but now when you do neck flexion, it just picks it up a bit, pulls it up a bit, and that reduces the pain. It's worth, if you're going to use traction on these patients and doing it laying down and doing it the standard way, pulling from the bottom and anchoring the top, if that doesn't work, or it makes them worse, it's worthwhile spinning them around on the bed and pull from the top and anchor the bottom. And that way you're actually lifting it off. It may work for you, it's worth trying anyway. And these people are often going to have a deviation that deviates away, towards the painful side. Because deviating towards the painful side actually lifts the axilla over the disc a little bit, takes some of the pressure off, and that's their antalgic position. And so you'll find pushing them into the deviation actually helps. It's a very difficult thing to treat when you see that. So normally when you're trying to do Mackenzie shifts, you push away from it. But in these cases, you push towards it, and then it becomes a real issue because you're pushing them into the deformity. But it's an antalgic deformity. Okay. And of course, Lateral test is just a variation in how you're doing this. There is, hang on a minute. It's just something else about this Cyrus, and I forgot what the bloody hell it is. The hell is it? Anybody know? Let me have a look. Talk amongst yourselves for a minute. I better not take that one. Oh, no, that's not telling me. I'll see if I can find it because it's just all the SARS is basically you flex the hip to 90 degrees and straighten the lower leg out. Then you can do all the other stuff with it. But there was something about it that's a little different. I'll see if I can find it. I can't remember what it is now. But basically, it's a variation in the way you're doing a straight leg raise. Okay, any questions on any of that? Okay, so these are positives. Neck flexion, Lermich sign is undoubtedly the most dangerous thing you're going to deal with here, the most urgent thing you're going to deal with, okay? Upper limb dynamic tension test, neuropathy, plexopathies, radiculopathies, all of these can do it. They will also, to an extent, when you first start doing the test, move the dural sleeve. Now, one thing you can do is if you get them in that position there and they're getting pain, and then none of these things, and somatic pain, and none of these things change it, then it's probably the dural sleeve. You have no idea which dural sleeve, but it's probably a dural sleeve. If these do change it, then the dural sleeve may be involved, but so is something else involved. And that may be the nerve root. But all of these nerve root movements and nerve movements should give you neuropathic symptoms, all right? Paresthesia, coarsalgia, lancinating pain. If you're not getting that, it isn't neuropathic. Hand on head, a low cervical T C7 radiculopathy. If you're getting rid of the neuropathic pain, it's a radiculopathy. If you're getting relief of somatic pain, it's a dural sleeve. There may still be a radiculopathy there, but it isn't producing neuropathic symptoms. Is that okay? And you'll have to test now to see if there is. So, but it's going to be unusual for you not to get hypoesthesia with paresthesia. Without paresthesia, it does happen, but it's going to be unusual. Scapular retraction, T1, T2 radiculopathy. And again, it depends on whether there's somatic pain. So it could be a radiculopathy without neuropathic symptoms, or it could simply be a dural sleeve compression. Slump without leg maneuvers. Myelopathies. If it's somatic, then it might be the spinal meninges, but that's not good neither. Okay, because you have to wonder what's bothering the spinal meninges enough to make them painful. And really there you're looking at an inflammatory condition such as meningitis, or you could be looking at tumors, or it could be a disc herniation that's just not got around to giving you neurological symptoms from this. Okay. Prone knee flexion, again, neuropathic symptoms. It's a radiculopathy, somatic pain. It could be a dural sleeve problem or a radiculopathy that isn't symptomatic for neurological symptoms. Slump tests, exactly the same stuff. Just remember what we was talking about. You're getting compression loading and flexion of the lumbar spine. So this is easy enough to confuse with between actually a structural problem in the spinal joints and a disc and what the hell's I'm looking for here, and also a neuromeningeal problem. Same with the straight leg raise. So is that okay, everybody? Have you got any questions there at all? No? I'd say with all of these tests, I don't think neuromeningeal tests should be done for diagnosis routinely. Unless you're suspecting that the neuromeninges are involved, then neuromeningeal tests are no more appropriate than looking for fracture tests when there isn't a fracture suspected. Now, having said that, both of those things can be used for safety issues, but not for diagnostic purposes. You might want to complete the exam. So your worry there, or your concern, is premature closure. I've closed the exam down too soon, and it may be I'm missing this. So you do them for closing the exam off completely. It may be because you're worried about anchoring, and you've anchored. You think you might have anchored to a piece of information that's giving you the wrong diagnosis. So again, you come up with differential diagnoses, and one of them may be, well, perhaps this is a stenotic problem with dural overlay. Let's test the dura. So there's reasons to do them outside of diagnosis, and that's mostly what you're probably going to be using them for. But the reason to use them for a diagnosis is because you suspect that the neuromeninges are involved. And of course, you can also use them for etiology. Is this multiple or double crush problems? Okay. I'm actually trying to think of a single case, a single test that should be done routinely on every patient who comes in. Can anybody think of one? Something as simple as range of motion, I don't care. Can you actually think of anything that you would want to do on every patient who came into your clinic? Say with neck pain.
I always do like alar and transverse ligament testing just to as safety.
Okay, what if you suspect there's a fracture there?
Probably wouldn't do it.
Yeah, so there's one exception. What if you suspect there is an instability present? Would you do it then?
Potentially not, depending on how confident I feel with that suspect. Like,
Well, you don't have to feel, if I think that they may have an anterior shear instability, I'm not going to call it transverse ligament. If I feel they've got an anterior shear instability and that the transverse ligament is incompetent, but it's probably due to a bit overriding neurological or overriding condition. But why would I test that when I already suspect that? Because if I test it and I'm right, I might actually do them a fair amount of damage. Now, how much suspicion do I have to have before I don't do that test? So we go back, let's look at sharp PERSA. The transverse ligament test is not as good as the sharp PERSA test. And I say that with some degree of confidence. Sharp PERSA test has been researched. We know the sensitivity and specificity of it. The transverse shear test hasn't. Now, that's not to say that it isn't better. So the fact that it hasn't been researched doesn't mean to say it's not better. It just means it hasn't been researched. But we do know that you need at least 4 millimeters or 3 millimeters of displacement before the cord is compressed. Yeah, and you get symptoms. Sorry, I'm lying. 8 millimeters of displacement before the cord is compressed, and you can expect neurological symptoms. The transverse ligament test is designed to produce symptoms, neurological symptoms. So I know it's at least 50% and possibly 60% less sensitive than is the sharp PERSA. I also know that that test isn't at all sensitive if you haven't got at least 8 millimeters of displacement. So I know that the sharp PERSA test is going to give me better results than the transverse ligament. Now, the sharp PERSA test means all I'm going to do is ask them to put their head forward, flat nod, basically. The reason I wouldn't do that is if I suspected there was a fracture there. The reason I wouldn't continue with the test is because that nodding movement produced neurological symptoms, in which case I wouldn't do the sharp PERSA test. Yeah. There really isn't a single test that you can apply safely and effectively to every patient who comes in your clinic. I could do a cranial nerve exam because it doesn't involve moving the patient, but why would I do that if I didn't suspect there was a cranial nerve problem? And as you just said, you would do the transverse shear test in order to make sure that things are safe. I haven't really got a problem with that. I've got no problem with that at all. But it's not a diagnostic test unless you suspect there is a problem. And if you suspect it enough, you shouldn't be doing it anyway. So it's a routine safety test to make sure of. And if you think about it, have you got any fracture tests you do for the upper cervical spine? Have you been taught any?
No.
Well, good. Because these were taught, I've taught them till I started to think a little bit better than I was when I was 15. Think about it. If I've got an undisplaced dens fracture, there are tests for this. You do transverse shearing across the ring. And it used to be, I don't even know if anybody's still testing it. They may be teaching this for all I know. It's to test the integrity of the dens. Have you never heard that phrase? Let's test the integrity of the dens. Nobody's heard that? Thank God for that. Because if it's not integral, then you just tested the bloody thing and displaced the fracture. So I seriously can't think of a single test that I would do on every patient who walked into my clinic. Your exam has to be tailored for the patient, not the patient tailored for the exam. So you make your hypothesis, do the test that will confirm or refute that hypothesis, and then produce a new hypothesis or make that your diagnosis. If you think about it, it's good practice. Do the least amount of testing you need to do. Just our testing doesn't cost very much. You start looking at imaging and blood tests and that, it does crop up. And that's really why they do it in medicine. But if you look at the imaging protocols, C-spine rules, Nexus, LRC, and all the rest of this stuff, every single one of those imaging protocols is designed to stop you testing when you don't need to. Not one of them is about diagnosis. It's about not doing something because it's unnecessary. Finally, if you're not sure whether you've got a fracture there or not, do an X-ray. That's the way it works. But you should be sure about the protocols. Yeah. Okay. That's essentially that video. This is going to be interesting because I've got an hour to do 3 videos with each kids. But that one's important. I think that's really quite an important one to do. Those neuromeningeal tests are often very, very mispracticed, misunderstood, and just done badly sometimes. Okay. I blame the teachers. There you go. All right, guys. Got anything for me before you go? All right. Okay, I'll send the recording out to you, and I'll send the other 2 videos you can have a look at. Maybe we can chat about them next time. It saves me having to think about what to talk about with you. All right.
Thank you, Jim.
Jen?
Thank you, everybody.
Thanks, Jim.
Bye.
Thank you.
Bye.
Thank you.